Don Mottner is here today as the co-chair. I just want to let folks know at the start of the meeting of a couple of updates. One is that we do have a vacancy in one of the management seats. Kate Nass has resigned from her seat. Folks may know she was promoted in her position and she's not able to continue to serve on the board. So we certainly appreciate the several years of service that Kate Nass has given our board. Additionally, we have a couple of folks who are out absent today, who have conflicts or are sick. So just want to name that Andy Foltz, Rob Nose, and Chicky Flowers are all excused today. But I do see folks on here, so we should have a quorum. Dawn, I can see that you're present. And Kimberly, I see you're present.
Here, thank you.
Sean, I see that you're present.
I'm here.
And Greg, I see you too.
I am here.
All right, so 5 of us are here. We have a quorum. That's great. We have some important business to finish up for our 2024 plan year. I also want to apologize at the beginning. My schedule has me a little tight today. And I know that we have another PEB member who has to hop off for a meeting, hoping to get through the votes in a timely manner. And Dawn will be taking over for me as vice chair when I have to be in a car and be driving so that I'm not leading a meeting and driving. So the hope is we make it through our votes. And then I know we have some reports. So the first thing on the agenda is to approve the minutes. I want to flag to you all that we got some updated minutes in our inboxes right before the meeting. I have checked those minutes. They look good. I don't. 3 things that needed to be updated. It was just making it clear that on our first motion, those were COVID over-the-counter tests. On the third motion, January 2024 is when we would look at the anti-obesity medications after a deep dive in the fall to see if we can learn more, if we're going to adopt any changes for a mid-year plan review. And then the fourth one, just reminding that we have a $35,000 maximum for pharmacy and medical combined for IVF. So just wanted to flag that those pieces got updated in the notes that were sent to us. So do I have a motion to approve the notes, the minutes?
This is Kimberly. I make a motion that we accept the minutes as the new email that we received this morning as presented.
Great. Thank you, Kimberly. Do I have a second?
I can second, Greg.
Thanks, Greg. Okay, Dawn, how do you vote? You may have, it looks like you're talking about, we're not hearing you. You show up as muted. So we'll give you a minute. So there you go.
Let's try this.
Yes, that works.
Approve, please.
Thank you. Sean, how do you vote?
Approve.
And I vote to approve. Thank you. All right, so I think we move to our first order of business, which is the final rates and fees. And Andrew and Emery, I'll hand it off to you.
All right, thank you, Siobhan. Good morning, everyone. Glad to be with you today. I think we've got an hour for today's portion of today's board meeting. And so the primary focus today is going to be to approve final 2024 rates and fees, and there will also be a vote on use of reserve funds as well. And so with that said, I think we can launch right in. You know, as we do, we kick off these meetings with a recap of, if you could advance 2 slides, please. A recap of PEBB's vision for healthcare in the state, which is highlighted in this pink box and sort of embedded under the governor and OHA priorities and principles. And so this is sort of the highest level of strategic vision amongst these 3 slides, which sort of serve as a preamble for PEBB's focus on healthcare on behalf of its members. And so if we want to move on to the next slide, it gets a little bit more focused as we go through these 3 slides. This one I know everyone is familiar with, the health equity strategic pillars. And so, obviously health equity is the key strategy for PEB. And so all board decisions are centered on equity. And this slide and this framework is really a tool to help inform those decisions as best as possible. And so several of the final approved renewal decisions for 2024 do have significant implications around health equity. So expansion of services, advancing equity in rural parts of the states, as well as a few of the other changes for 24, which we'll review here in a few slides. And so this framework is a really valuable tool, and our health equity workstream is incredibly valuable as well. And so just want to say thank you to all who participated in that workstream. It really is a significant asset on behalf of the board as we look at all decisions through and centered on equity. I'm going to jump to the next slide. This is the third of these three sort of setting the stage type slides. And again, I know folks have seen this many times, but nonetheless, do want to make a few comments before moving into sort of the meat of today's presentation. And so, sorry, just looking at the comment real quick. So these goals, which are highlighted in blue on the right, include things like health equity, behavioral health, equity across the state, focusing on the whole person, member education, focusing on the needs of a diverse population, and ensuring the richness of the plan while maintaining costs and pursuing alternate payment models. Many of these were advanced during this renewal process. We'll talk about that in a little bit more detail here in a couple of slides. Some of these goals are worked on through other activities that collectively we all work on throughout the remainder of the year. We do have a retreat tentatively scheduled in October of this year. And so at that time, we're thinking we would sort of round out the view on how some of those goals are addressed through processes outside of the renewal process, just to give you a sense for the different ways that collectively we are working on and advancing each of these goals. Okay, I think we can jump ahead to slide 8. These next few slides are first here a recap of decisions that have been made by the board thus far, as well as some other things that have come up that we want to update you on since we last met a month ago. And so this list is a running list of all the approvals that the board has made for changes for 2024. Most of these you have seen, however, some of these are new based on approvals that were made last month in May. And so some of the new items include expanding eligibility for facial electrolysis on the self-insured plans, adding the Spring Health Behavioral Health Network to the MODA plan, adjusting the ER copays for Kaiser for both plans, and enhancing the fertility benefit as well to remove the pharmacy limit so that benefit is gonna go farther for your members who are using it. And so there's really good alignment when I was reviewing these. I think there's good alignment between these approvals and PEB's long-term goals. And so in terms of advancing health equity, behavioral health, further achieving plan equity across the state, ensuring that the benefit maintains richness, but also managing cost. A lot of those goals were advanced based on these 15 or so approvals for 1/1/24. Okay, let's jump to the next slide. This is an update based on an audit that has been happening for a long time now. This is about a year in the making. And this is an audit that CMS has been doing with PEB's self-insured Providence Health plans around mental health parity. And so the Mental Health Parity and Addiction Equity Act is a law that, at a high level, it requires that mental health and substance use services be treated no more stringently by a health plan than comparable medical and surgical services. And so with this audit, CMS and the third-party investigators who have been conducting the audit have been looking specifically at outpatient prior authorizations. And so there are two such prior authorizations in the Providence plans for mental health and substance use services, and those are ABA and TMS. So ABA is applied behavioral analysis, TMS is transcranial magnetic stimulation. And so, as I said, this audit has been going on for a long time, about a year. Collectively, we've done a lot of analysis. We've had a lot of discussion. Providence has put in a ton of work, and I want to acknowledge that, a ton of really good work. At the end of this year-long discussion and analysis and back and forth with the CMS investigators, ultimately the recommendation was to remove prior authorization for these two services. And so doing so, there is a financial impact, whenever you're going to remove a utilization management lever. However, in this case, it's not a very significant financial impact. And ultimately, this is what is, we think, going to put PEBB in the best position to pass this audit. And so the final submission was submitted yesterday. And so at this point, the audit is complete. It's possible the investigators might post some clarifying questions, but for our intent and purpose, the audit is complete. And so we will hear back perhaps in the next few months based on their final determination. But we don't have an exact date that we'll hear back on that. And so that was, I realized that was a lot. And this is a topic that, we've touched on here and there over the past few years. And so I'll pause there, see what questions folks have based on analysis that was conducted or final documentation that was provided to the investigators. Yes, Ali.
Thanks, Andrew. I just wanted to add a quick comment that, we had to act fairly quickly once the report came back from CMS. They, I think, gave us 3 weeks, and the final response was due yesterday. So we worked with board leadership to I think that we would have been looking at potentially having to send letters out to all PEBB members expressing that we weren't in compliance with mental health parity and potentially other fairly serious consequences that, the financial impact, as Andrew said, is fairly small compared to, the potential risk that we were facing. So just wanted to add that quick comment. Thanks.
Thanks, Ali. And this will make it easier for our members to receive mental health services without when we lift that pre-authorization. Just wanted to make that clear too. So this will be better for folks in Providence.
Yeah, thank you both. Okay, if no further comments, I think we can move on. So this is a little bit of an unusual slide in the sense that, at this point, typically we would be past best and final offers from carriers with regards to their renewals. However, MOTA has proposed reducing their ASO fee for 2024. And so again, in a normal year, we would not accept a revised renewal at this stage. However, MOTA has made this offer in a show of partnership since they too are hoping to achieve low-cost plan status. And, we are going to be asking you to vote on that here shortly. And so what MOTA has proposed here is to reduce the fee, to hold the fee flat essentially for the first 3 components of their ASO fee, which are listed on the right there. And so their base fee, their utilization case management fee, and their DM fee. And so, in reducing those fees, it doesn't bring the plan to low-cost plan status, but does get us closer to the tune of about $100,000 in reduced fees. And so, again, a little bit unusual, and not something that would come up in a typical year, but nonetheless, we did want to put this in front of the board, see what questions you have, and then ask you to vote on it.
So I think this is the point where we ask questions, and then I'll see if we have a motion. I wanted to comment that when MOTA came to us and requested if they could make a reduction as board leadership, I said, yes, you can make a reduction, and we will certainly consider that and vote on that. So just want to know if folks have questions, or I can take a motion that we accept this reduction.
Last meeting, I'm just trying to get, last meeting, did we, the MOTA 360, is that in here now as moving forward? Because I thought last meeting that wasn't in, just so I'm clear.
Want to comment on that, Andrew?
So the MOTA 360 is a separate fee from the Behavioral Health Champion 360 program. The Behavioral Health Champion program is not included here. However, the 360 Navigator fee is included.
And we've had the 360 Navigator.
Correct.
This isn't
Yeah.
the first time, but and we're only adding Spring Health. That's what we discussed at the last, so I can see that listed
Sure,
separately.
which one we had added, and that's what I was trying.
I think it's confusing too,
Sure.
Greg. I mean,
Yeah, we added the Spring Health piece, but it says we have the MOTA 360, so I wanted to make sure we were correct on where we were getting and not getting what we, because we had dropped one to pick up the other.
do I have a motion?
I'm still confused, sorry.
Yeah.
I'm looking at the minutes that we just approved, and it says that we, MOTA 360 I moved to approve the recommendation of consultants to decline the MOTA Behavioral Health 360 program and implement Spring Health on a standalone basis. Greg seconded it. And now I'm seeing that we are, yeah, please.
So yeah, thank you for bringing this up. It could have been more clearly outlined in the table. Yeah, the MOTA 360 fee, which exists today, which is the $524 per employee per month fee in blue there. That is a fee that is not specific to the behavioral health navigators. That is just a fee that covers the navigators that are in place today with the MOTA managed plan. And so what MOTA had been proposing was the Behavioral Health Champions program, which would come with a new sort of tier of navigators who were just focusing on behavioral health and trying to navigate folks to the appropriate behavioral health substance use service, following up with those members, that sort of thing. That component is what the board declined. However, the base navigator fee, which is already in place today, and is outlined as the MOTA 360 row, is still in play. It's the new fee around behavioral health is the Spring Health, which is just above the purple row, which was an alternative solution to the MOTA Behavioral Health Champion program. And so I don't know if that it helps clear it up or not, but
Call them both MOTA 360, but one is a standard fee that we have to take because we have MOTA. The other was called MOTA 360, but it was in the behavioral health side of MOTA, and that's the one we declined, if I understand you correctly.
yes, correct. Yep.
When I saw that, that's all. And thank you for bringing that up, and reiterating it, because I was sure that we had declined the MOTA 360, but a different MOTA 360 we had declined. I got it.
Yeah, no, thank you.
Any other questions? Dawn, go ahead.
Nope, I was going to bring it back. No more questions from me.
Do I have a motion?
We already had a motion.
Oh, we had a motion? Who made the motion? I didn't catch that we had a motion. Greg, are you making a motion? Sorry, I didn't catch it if you said you were.
Did Kim make the motion? I believe I seconded, and then we have the question, correct? Or am I wrong?
Oh, Kimberly, did you make the motion?
No, I didn't, but I can. But no, I did not.
Oh, okay.
My bad.
I don't, okay, no worries. Kimberly, you're willing to make the motion, and what's your motion?
My motion is to accept the recommendation to accept MODA's revised proposal as presented on this slide by Mercer.
Okay, thanks, Kimberly. Do I have a second?
I can second.
Thanks, Greg. All
Sorry.
right, Don, no worries. Don, how do you vote? You're showing up as being on, oh, there you go. Go ahead, Don.
I vote to approve.
Thank you. All right, Sean, how do you vote?
Approve.
Thank you, and I vote to approve. All right, the motion carries. I think we can move to the next slide. Thank you, Andrew.
Sure thing. And I think I'm going to pass it off to Emery now to talk about the composite rate and a potential funding vote.
All right. Thank you, Andrew. So this slide shows the plan rates, and the reason we show it is really concerning just to kind of give you an illustration of which plans are going to be considered low-cost plans, as well as the lowest cost plan for the OUS employees who are eligible for the 3% contribution rate. But at the top, you can see the rates. The statewide plans the most widely available. And then we show the 4 plans over to the right, the Kaiser HMO, the Kaiser Deductible, MODA, and Providence Choice. So the MODA rates you see here do include that decrease for the admin fee. And that brings them in at 9.7% below statewide. The threshold for being a low-cost plan for the majority, the non-OUS employees, is 10%. So you can see the rates currently do not meet that threshold of being the one low-cost plan and being a low-cost plan and having that 1% contribution. The Kaiser Deductible and Providence Choice plans do. They're both in at 10.9% below statewide. And if you look closely between Kaiser Deductible, which is in the middle, and Providence Choice, which is on the right, you can see that Kaiser Deductible is actually a little bit cheaper than Providence Choice. So what that means is that the Kaiser Deductible in the counties that's eligible in will become the lowest cost plan for OUS employees, or remains that way actually, and then Providence Choice would be second. So I don't think that's actually going to be pretty much status quo. But MODA currently is not quite yet at 10% below the threshold to reach statewide, compared to statewide, to get to the 1% contribution. If the board elects to essentially use funding reserves to make MODA a low cost plan to receive that 1% contributions, you could essentially reduce the MODA rates to get to that threshold. And what that would require would be about $0.67 million or $670,000 in funding in order to have MODA achieve that 10% threshold. So if we move to the next slide, what we show here are 2 sets of rates. So the top rate at in the top section, the top 2 tables, shows you the full-time and part-time rates as is, without spending reserves to get to that 10% threshold. That's about 5.9% increase. It does include premium tax, but does not include the PEBB Administration Consultant Commission and any other funding assessment that the board may decide to do. So this is based on the decisions made as of, well, just now and the May board meeting in terms of the plan design changes. The bottom rates, the bottom 2 tables, shows the rates if the board elects to use funding reserve to bring down the rates to reach that 10% threshold. So that'd be about a 5.5% increase and would put MODA at 10%, exactly 10% below the statewide rates. So what we're asking the board to make a decision on is to whether to spend about $700,000 in reserve to essentially bring down the MODA rates to that threshold to be the 1% contribution. So the board decision, you could either elect to keep MODA as is and be 9.7% below statewide and not have that 1% contribution, or spend reserves down below of $700,000 to potentially get to that 1% contribution level. So, for a Mercer recommendation, I think based on the number of members, I mean, there are 9,000 employees, 9,000 plus employees who are currently enrolled in MODA. Majority of them would, if you do not elect to spend reserves, would end up having their contributions increase if they did not choose to change plans from 1% to 5%. So, I guess, the option, Mercer recommendation would be to potentially spend that reserve to bring down the MODA rates so that the members would not see a large increase in their contribution rates. But I pass it over to you, board chair.
All right. Thank you, Emery. So there was just a couple comments that I wanted to make around this. I know that one of our equity goals is to pay attention to folks who live in rural areas. If we continue to have MODA as a low-cost plan, that means people have a choice of whether it's Providence or MODA in the rural areas of the state. We know the metro areas also have access to Kaiser, not the entire Willamette Valley, but much of the Willamette Valley is certainly where the largest number of folks live. So I wanted to just make sure we're paying attention to equity around this vote. The other thing that I want to highlight is when we had that discussion a month ago around IVF, we knew that this was going to add costs, a larger cost to MODA, because for whatever reason, we didn't do a deep dive into the reasons, but more people who are seeking IVF are utilizing MODA. And so that vote and that change did mean that we needed to potentially look at planning for, I believe the estimates were a few $100,000. So I just wanted to remind that we made that decision around that as well. And then we added the spring health because of the struggles people have getting the mental health care that they need. So I just wanted to raise those things when we consider this particular vote. Do we have any questions around this or any comments? Go ahead, Greg.
I know that we've talked about it before. What are reserves at?
I don't have the number off the top of my head, Ollie. I don't know if you have it handy. I think it's close to $1 million above the surplus, or maybe I'm misstating it.
Yeah, we'll have an update, an RBC report, I believe, next month in July. But yeah, are you talking about this year, Emery?
Yeah, I guess for 24, that's the time period we're looking at.
Yeah, I mean, I would express it maybe as far as where we are above a fully funded reserve target, relative to a potential fund sweep that we know is out there. And the last I looked, Emery, and I guess we'll see more next month, but we were still well above fully funded, even with the fund sweep, by 30-40 million, at least at the last report. Of course, there's still risk in future years that we'll look at next month. But as far as the current position, we're still well above fully funded reserve status.
I was just looking for an idea. Thank you.
Yeah,
So-
the amounts would not really impact where you are in terms of fund.
Yeah.
Go ahead, Sean.
So I appreciate all that context, Siobhan. Thanks for that. With that, I'll make a motion that we accept that we use reserves as detailed here on the slide at the bottom, accept Mercer's recommendation in order to have MODA as a low cost, competitive plan in particularly those rural areas.
Thanks, Sean. So we have a motion. Do we have a second?
Second, right.
Thanks, Greg. All right, Dawn, how do you vote?
Approve.
Thank you. And Kimberly, how do you vote?
Approve.
Thank you. And I vote to approve as well. The motion passes. Thank you, Emery.
Yep, thank you, Sean. So moving on to the next slide. This slide shows the composite rates as in terms of where PEB is versus the 3.4% limitation. So, where you, well, actually, you're a little bit below. So where you take a look at, you have 3 rows of 2024. So where we want to focus potentially is the preliminary. And you're actually just a little bit below that with the decision to essentially use reserves to fund for MODA. The next line we can ignore, the 4.59 funding assessment. We can ignore that. But if we go to the bottom line, with the MODA buy down, you could apply a 0.519, basically 0.5, half a percent funding assessment to the medical plans to bring you to the 3.4% limitation amount. Currently, you are below that 3.4%, a little bit, about $5.5 million below. So essentially, if you elect to not apply a funding assessment, that lower level of funding is carried forward to the next year. So the 3.4% increase is then tied to that lower amount. What the PEB board has done in the past, and including last year, is to, when you're below the 3.4% level, is to apply a funding assessment, essentially to add to your reserves, essentially to, I guess, partially pay for what the low cost plan status for MODA, and this additionally, with the mental health parity change as well. So what you could do is apply essentially a funding assessment to about 5% or 0.5% to get you to that 3.4% level, and therefore next year your rates would be limited to about 3.4% above this new higher level. So it kind of adds a cushion over multiple years. Can we actually move back? Thanks. So what Mercer is recommending is to essentially apply a funding assessment of that 0.519 to achieve that 3.4% funding composite rate increase for 2024, and thus, add a little bit of buffer for 25 in case the rates do come in a little bit higher than essentially your limitation level. So I guess, just potentially add a little conservatism, increase the reserves a little bit to help offset future cost increases if you do apply this 0.5% funding assessment. So with that,
All right. Did Emery freeze?
I think Emery
Okay.
did just for a second. Yeah.
Okay. Go ahead,
this
Sean.
This is one of those things that we've done over the years as a way to adapt to kind of what I would characterize as sort of a blunt instrument of the legislation that ties us to 3.4%. The way the legislation is written, or the way the law is that we get basically kind of punished if we actually beat our own 3.4% cap, because we can never average together 2 years or more to say, there was this one year that we came in at 1.9%, and then there's another year where we came in at 5%, and when you average them together, or under 3. We never get that opportunity. We always have to meet 3.4% exactly every year. And there's no kind of reward, if you will, for coming in under. And that's just the way it's written. And so we kind of like build in a little barrier to sort of accommodate this, because it's almost like you're punishing yourself if you come in under it, because the next year you're tied to 3.4% above that. So if it's like an average, you end up over years, if you have 1 year where you're under 3.4%, that means on average you're under 3.4%, because when you average them together. And so this has just been like a way that we've accommodated this kind of limitation in the law. So that's yeah, that's for context, we've done this a few years, and it's sort of like a way to adapt to this kind of blunt inability to average together years. It still, I feel like, still keeps the intent of the law, which is basically like an average of 3.4%. But there's others. But you're still around that line. So I would I guess we do. I mean, we need to vote on this. We need a motion.
We do need a motion. I was going to see, I appreciate you explaining the context. Are there any questions about this from folks who this is newer for? Go ahead, Ollie.
Yeah, the plan is for next month as part of our RBC report is to bring some thoughts around this discussion that, or this issue that Sean just raised, and potentially look at some policies the board could put in place to address it. One obviously is to propose a legislative concept to change how that 3.4% test is calculated, and but I just wanted to kind of tee that up for next month, that we'll have a little bit more in-depth discussion around this.
Thanks, Ollie. So yes, we do need a motion. Are there any other questions or comments, or do I have a motion? Okay, I don't hear any questions or comments. Do I have a motion?
I'll make a motion to accept Mercer's recommendation of adjusting the rate. I don't know. What's the right way to say it?
I think that's right. Of the 0.519%, I believe is what it says on the slide.
Applying a funding assessment to get to the
Okay.
3.4% composite
Funding
rate.
assessment. Yeah. So
All
moved.
right. Thank you,
This is
Sean.
Kimberly.
Go ahead.
I'll make a second.
Thank you,
Sean's
Kimberly.
motion.
Thank you. Dawn, how do you vote?
To approve.
Thank you, Dawn. And Greg, how do you vote?
Approve.
Thank you. And I vote to approve as well. All right, the motion passes. Thank you, everyone. So I believe it goes back to you, Emery.
Yes, although I'm going to hand it back over to Andrew to go through the final rates for everyone to approve in this case.
All right, thank you much. And so if we want to jump to slide 17, for the remainder of the slides, it'll be approving final rates and fees for medical, dental, and vision. We've already done MODA a couple of slides ahead, and so we'll do Kaiser and Providence here in this section. This first slide is Kaiser's HMO rates. These are the final rates with an increase over 23. The way we split this out is to show full-time and part-time rates for both HEM and non-HEM rates. This is prior to PEBB administration, consultant commission, and funding assessment. It does take into account all plan changes that the board has previously approved, and it does include the 2% premium tax. So I'll pause there and see if we're, yeah, go ahead, Siobhan.
So we're going to approve Kaiser and then Providence. So I just need a motion to approve what we've already essentially approved, any changes. All right, do I have a motion to approve the Kaiser rates?
This is Greg.
Greg?
I can make a motion to approve as written and presented by.
All right, thanks, Greg. Do I have a second?
I'll second.
Thanks, Dawn. All right, Kimberly, how do you vote?
Approve.
Sean, how do you vote?
Approve.
All right, and I vote to approve as well. Thank you. Motion passes. All right, let's go to the next slide.
Right, and so we will ask you to do a similar approval. This time we are on the Kaiser deductible HMO plan. And we've split out the rates in a similar way, and this also has is inclusive of all changes that the board has already approved.
All right, thanks, Andrew. Do I have a?
This is Kimberly. I'll make a motion to approve the Kaiser deductible HMO as presented.
Thank you, Kimberly. Do I have a second?
This is Greg. I can second.
Okay, thanks, Greg. All right, Dawn, how do you vote?
Approve.
Thank you. And Sean?
Approve.
Okay, and I vote to approve as well. Motion carries. Let's go to the next slide.
Okay, same idea here. Now we've moved on to Providence. This has both the statewide and the choice plan, statewide across the top and choice along the bottom.
All right, so do I have a motion to approve?
This is Greg. I can make a motion to approve this as written by,
All right, thank you.
for both points.
Great, thanks. I should have just said, do I have a motion? But anyway, do I have a second?
I'll second.
Thanks, Dawn. All right, Kimberly, how do you vote?
I vote to approve. Thank you.
Thank you. All right, Sean.
Approve.
All right, thank you. I vote to approve as well. Motion carries. All right, thanks, Andrew.
Let's jump ahead and we will shift gears to dental. The first of which is Kaiser Dental, 2% decrease from 2023. And so Siobhan, I'll pass back to you.
All right, do I have a motion for Kaiser Dental?
So moved.
Thanks, Dawn. Do I have a second?
This is Kimberly. I'll second it.
All right, thank you. Sean, how do you vote?
Approve.
Greg, how do you vote?
Approve.
All right, I vote to approve as well. Motion carries. Thank you.
Next one is Willamette Dental Group. These rates are flat from 2023.
All right,
I'm
looking for a motion.
Greg.
Thanks, Greg. Greg makes a motion. Do I have a second?
I'll second.
Thanks, Dawn. Kimberly, how do you vote?
Approve.
Sean, how do you vote?
Approve.
All right, I vote to approve as well. Motion carries. Thank you.
The next slide, we have your self-insured dental plan through Delta Dental of Oregon. The administrative fee is at the top and the accrual rates are in the three tables towards the bottom.
All right, thanks, Andrew. Do I have a motion?
I'll move to approve.
Thanks, Dawn. Do I have a second?
Second.
All right, thanks, Sean. Kimberly, how do you vote?
Approve.
Thank you. And Greg?
Approve.
I vote to approve as well. The motion carries. All right, next slide. Thank you.
Self-insured vision with VSP, again, ASO fee across the top, and then the actual rates in the middle there with a slight decrease in 2024.
All right, do I have a motion to approve?
This is Greg.
All right. Thank you, Greg. Do I have a second?
Second.
I'll second.
Okay, I think we have Sean just ahead of Dawn there. Dawn, how do you vote? Sounds like you
I'll
approve.
approve.
Kimberly, how do you vote?
Approve.
All right, I vote to approve as well. Motion carries. All right, thank you. Next slide.
So this is our final slide today. So thank you all for those votes. Appreciate it. This is our final renewal meeting for the year, which is hard to believe. And so the next time we sit down to talk about renewals in depth will be in January of 24. We start talking about 2025. That said, we do have some activities and work streams this summer and fall, which will inform decisions for 2025 renewal decisions. However, we will not have a renewal focused meeting again until January. We have all final decisions from you. We've already started working with carriers to confirm any changes, working with staff members as well to implement some new programs. And then once we receive the draft contracts and handbooks, Mercer will be reviewing those as well. Next month, as we've talked about, we'll have a utilization report where we look at some trends within your population, as well as an update to the risk-based capital report. And then, per Ali's comments, there'll be a discussion around reserve funding policy that the board might want to consider. We do have the retreat tentatively planned for October, at which point we can regroup on progress we've made towards achieving goals, as well as sort of reset before we start looking at 2025 renewals.
All right. Well,
Yeah.
thank you for sharing all the next steps. Look forward to these future discussions. I know we have a break that is scheduled for after this part of the agenda. We're going to take that break, and then I'm going to hand over the facilitation to Dawn so that when we come back, Dawn will facilitate us through our final updates today, our legislative update and our center's update and any public comment. I'll hop back on as I can and participate. Appreciate Dawn taking over for us. Any other comments before we go on break? Doesn't sound like it. I do want to appreciate all of our partners. I'm sure we're all paying attention to Providence nurses being on strike, and hopefully that will get resolved quickly. And we want to continue to work with all of our partners so that our members are getting the best care possible. So thank you all. This was a busy renewal cycle. And why don't we take a break? I'll put us up till 10:30. So why don't folks come back at 10:30?
Welcome back, everybody. Board members, please be sure your video is on so that I may see that you're back. Except for Siobhan. Some technical difficulties. So who do I see? I see Kimberly, Greg, Sean, and Siobhan is here but off. So I think that's all of us. And next up on our agenda is our legislative update. Glenn Bailey, are you on?
I'm here. Thank
I
you,
see
Dawn.
you, but I'm not hearing you. Can others hear Glenn?
I can hear.
Can
Glenn.
you hear me?
Yes.
I can hear him.
Yep, I hear.
Thank you,
Try a
Dawn.
new solution.
I think you can go ahead, Glenn.
Okay.
Go ahead.
Yeah.
Yeah.
I'm sure you all know that the legislature came to an agreement last Thursday that they would amend House Bill 2002 as well as 2005, which are a gun bill, and now they're back in session. So they are furiously going through bills and passing bills right now. There are still bills at the Joint Ways and Means Committee that need to be voted on and then sent to the chambers. Excuse me. And then sine die is June 25th. They have about a backlog of, from what I understand, about 400 bills. So what I wanted to do is kind of just give you a overview about where our bills stand right now that we have been following. And then also, I was going to just go over, since we've been getting inquiries about one bill in particular, just give you an idea on that bill. First of all, for our priority one bills, these would be the bills such as the global budget pilot. We have currently one that is awaiting House or Senate vote. That's actually in relation to the OEB board membership, and we have one enacted. And then that was House Bill 3140, which ended the 3-year contracting limit. And then we have one, which is the global budget pilot, that's still at Ways and Means. If Ways and Means has not sent it to one of its subcommittees, such as the Human Services, or right now Capital Construction is the main one that they're looking at, who does a lot of this work, then it's really probably not going to move forward. One other one that Ali just pointed out to me is Senate Bill 1049, which is the funding sweep legislation. 90 million has been scheduled in capital construction for tomorrow. So that will, be up. They're going to have a lot of bills to go through, and they have a lot of budget bills to go through. Fortunately, the OHA bill, made it through Ways and Means, but there are, a lot of bills that they need to get through. In regards to priority 2 or 3, these would be mainly benefit bills. We have 4 that have been enacted. 7 have been still at the Ways and Means Committee, with a number at one of its subcommittees. and then 10 that are awaiting House and Senate votes. Those are really kind of where we stand, and it's kind of changing daily because, like I said, they're working very fast to pass these bills that were in the backlog. One of the bills that actually is at Ways and could have an impact on both PEB and OEB is House Bill 3013. This is a bill to, it's really part of a kind of a suite of bills that have been going on for several years now to really put limitations on PBMs and to ensure that individual pharmacies get either a higher reimbursement or a lot of those cost containment strategies that PBMs use are kind of put in check, so to speak. This bill, there are several pieces to it. One would require a different methodology for reimbursement. We have gotten from MODA that they think that this possibly could increase rates by 0.2%. Again, there's a lot of definition that needs to go into this bill, and DCBS also needs to write its rules on that afterwards. So there's still a lot of indeterminate nature about this bill. The second part of it would allow people to choose where they're going to get their prescriptions filled in regards to pharmacies, and it's including specialty medications, which could have, most definitely probably will have an impact on us. But again, the carriers and Mercer are not sure at this time exactly what would be the impact in regards to premium. Again, this bill needs DCBS rules afterwards and know exactly when it will go into effect. But I did want to make everyone kind of aware because we are getting, inquiries about this bill. That's kind of where we're at in regards to the legislature. Hopefully they get through as many of the bills as possible by June 25th. And, it's they're working furiously, but, no one can really kind of predict at this time whether they're going to get through all these bills. Ali?
Thanks for the update, Glenn. I wanted to emphasize the House Bill 2002, the transgender health bill. It's really a huge win, and we will be implementing those statutes, so it will have an impact on PEB and OEB as well. I think, as soon as all this last 5 days play out, we'll have future discussions on that bill and kind of the impact on PEB and OEB and the rest of the state as well. But it was big news to see that move. So thank you.
Are there any other bills or that folks had questions on? I mean, in regards to what's, the bills that are going to impact us that kind of come out at the end, I mean, if everything they vote on, I mean, I see probably around 16. There could have been a lot more, of course, but because of the walkout, things really kind of got backed up in the legislature.
Any more questions or comments for Glenn? Thank you, Glenn. Appreciate your work with that. There's a lot going on. It's complicated.
Thank you, Dawn.
Next up, we have an update from Mercer on Centers of Excellence. I just want to acknowledge that we're running early here, and it sounds like maybe Emery and Cindy are going to talk with us.
Thank you, Dawn. Actually, before I start speaking, well, actually, I guess I am speaking right now, but Margaret wanted to say a few words.
Yeah, thanks, Emery. And thanks, everyone. It's great to be here this morning. I just wanted to kind of just give a little bit of background context before I hand this over to Emery and Cindy from Mercer to sort of walk through the slide deck. But this report today is really a comprehensive status update on the Innovation Workgroup's Centers of Excellence project. So today in this presentation, we're not looking for any decisions from the board, but we are interested in any questions, feedback, input, anything you want to offer related to the information you're going to hear. This report is going to include kind of a couple of different aspects to the update. First off, some background about sort of why a Centers of Excellence program and sort of the rationale that the Innovation Workgroup developed in terms of identifying this as an initiative. There'll also be an overview of the work done to date and sort of what has shaped the direction of the project and led the Innovation Workgroup up to this point. And also some discussion around the current project plans and timelines, which have evolved over the course of this project. And just to note as a reminder, the Innovation Workgroup does meet as a joint subcommittee of the PEBB and OEB boards. And Sean Parkman and Kimberly Hendricks are your PEB representatives on the Innovation Workgroup. They've been very engaged and very instrumental in offering their insight and helping move the workgroup's initiatives forward. And then also they participate with 3 members of the OEB board, JJ Schofield, Tom Siltebo, and Jeff Brown from OEB. So an update very similar to the one you're about to hear was provided to the OEB board just a couple of weeks ago at their meeting this month as well. And I will go ahead and hand it over to Emery to get things started. Thanks.
Thank you, Margaret. So moving on to the next slide. So we're going to cover a few items, as Margaret mentioned here, kind of basically why we're doing it, the history, and what we've done so far. We also want to talk about some values that the IWG has adopted regarding COE, and really, I guess, more, some of the things that the IWG would be working on in the future. And then we'll also cover the project plan, where we are going over the next year and a half. And then some of the work we have done in terms of clinical and quality. And Cindy is going to help speak to that. But moving on, why consider a COE? So, COE is one of those bridge programs, bridge things to help reduce costs and improve care for the PEB members as part of the values. It's really rooted in quality base. And the reason why the COEs came up, especially with hip and knees, is because we were looking at costs for OEB and PEB in terms of what are the biggest costs, and musculoskeletal was one of them. And, when we took a look at musculoskeletal, knees and hips, they are on the additional cost tier. They are kind of like a preference sensitive surgery. You can choose whether to have a knee or hip replacement in many cases. And what we also saw was that there was, quality differences, and there was definitely some complications, some readmissions, which, are very impactful for the members. It's a big cost overall, not lots of surgeries. As you can see down below, about $63 million total for OEB and PEB at the time. Lots of surgeries, over 1,400 annually. And, there was member complications, failed surgeries. We're talking, potentially up to 80 members who were impacted where, you have a surgery that essentially failed or did not work as planned. And so you have those complications of additional issues from that. And some of the care may be unnecessary. Not everybody needs knee surgery. And part of what we're trying to address on the COE is to find out, get the members who are in the best position, or get them to the best position to potentially have that surgery if they do need it, but they don't need it, potentially find some lower impact ways of improving their condition. So that is part of the background of why we selected a COE. Next slide. So, just in general, the value of the COE, what we wanted to do was to prioritize early intervention. So basically get people before they get to surgery to find, get the best doctors, the ones with the least complications, readmissions, make sure they're best suited for that surgery, that they meet the member actually has, in the best possible condition to be successful in that surgery, and to design a program that's going to help steer members to those facilities and providers who have the best quality. And therefore, you can improve the income outcomes, you can reduce the complications, you can save money by having fewer readmissions and complications, follow-up surgeries and or other procedures in this case. So that's really where we currently see the value of a COE program. In some cases, yes, you can try to do bundle pricing, episode pricing. That is part of what we want to focus on. But right now, that's stage 2. And so moving on to the next slide. What we wanted to show was some history on additional information about the knees and hip surgery. So what are we talking about? We had talked about 1,400 previously per year, and that's for OEB and PEBB. For PEBB in total, you can see at the top the number of surgeries, and for current time period, that's really the 12 months through November of 22. And you can see that the surgeries actually have decreased a little bit over time. Prior to would have been essentially 2020, and then prior is 2021. So you can see that the surgeries have decreased a little bit, but you have about 500, 600 surgeries. And one interesting thing is that there are a lot more outpatient surgeries. That you can take a look at the prior two. A lot more surgeries were done inpatient. As COVID has happened and as care has changed a little bit, a lot more are being done outpatient. So the vast majority now of these knees and hip surgeries are being done outpatient. There's additional information down there below for OEB and PEBB in terms of the members of where the members are situated that are getting the surgery. But we move to the next slide. This slide kind of shows there across from left to right where the member is in terms of the different regions of the state, as well as where they're having the surgeries. So the facilities that they're having the surgeries is from top to bottom. So you can take a look at, they are in the same order across both the top and across. And so you can see the central Oregon, the Bend area. You have the coast, you have the metro area, which is Portland, northeast, southeast, and then southern, which is, kind of more Medford, Grants Pass, that area. And then the Willamette Valley, which is, Salem and Eugene. And then you have the members that are out of state. So you can take a look at where the members are from left to right and where they have the surgeries. And those members who are staying in the same place, same region for the surgeries is the diagonal that goes from top left to bottom right in the boxes. But overall, you can see that over a quarter, about 28% of members actually travel out of the region for surgeries. And so what we want to do with the COEs to, if you are going to have to travel or want to travel for surgery, making sure that you're finding that you're going to the right providers, that the providers are the best quality and potentially the best price. And so that's part of what we're trying to achieve with the COE. For those members who do travel, let's get them to the right places. And those who do stay in the region, potentially in the metro and Willamette Valley region, you could have members, you do have options of where you potentially want to have that surgery. And let's make sure you're going to the right place in that region to have the surgery. But generally, the people who travel the most are on the coast, which kind of makes sense. They do go south and essentially go down to the I-5 corridor. They go to the metro area or, up and down the corridor, depending on where potentially, I guess, where they live. Some do have surgeries on the coast, but the majority do travel to essentially the Willamette Valley's metro area of Oregon. The Northeast region, which is the fourth column over to the right, they travel as well. Most of them do go out of state. So, crossing the border potentially to Washington or Idaho. Southeast region, people are moving out, going to out of state. So Idaho, generally in that case, although a couple did come over to Oregon, to Central Oregon. And then the rest of them potentially travel about 25 to 15% of the time. So there are definitely people who do travel. Let's make sure that, the people who have to travel the most are getting to the right places. Any questions before we move on? Okay. Next slide. Of the COE. So for some of you who haven't been as intimately involved or in the IWG or the COE, we started looking at this in basically 2021. We were looking at COE, trying to steer members to the high quality providers. In 22, Mercer took over the project. And what we did was to take initial ranking of based on the data in terms of quality and trying to take a look at that. So we did take a look at in November, and what we found was, there were definitely questions that were raised based on the data. The data set, we did have clarify which Mercer subcontracts with and doesn't have complete data. And we also used APAC, which has all of Oregon. So it's the all payer, all claims database for Oregon. So essentially the vast majority, 95, 99% of Oregon surgeries were in the APAC data. But we had 2 years of information, and what the IWG wanted to take a look at was actually kind of expanding that APAC data over multiple years, just so that we can make sure that we have the right data set when we're taking a look at the quality of the providers and making sure that everyone's on board in terms of what is a quality provider. So what we decided to do was to rerun the data with multiple years, 4 years plus of APAC data, to take a look and rank and sort out the facilities and take a look at the quality of the facilities in this case. So starting in 23 there on the right, January, we started identifying a data partner. We also worked on potentially plan design in conjunction with the PEBB board, the travel benefits, and some of the other things. And then in March, we started holding some conversations with interested parties about the COE to really review the COE, the concept design, the data, and all of those other things. So that's where we last left it. And then next slide. We had some feedback from those conversations with the interested parties. So what we heard was that we were looking at a plan design that potentially would tier the facilities, in terms of trying to really drive member via cost, member copays, coinsurance, as well as reducing that barrier to what we would consider top tier facilities. And what we found, with not only with just the providers not necessarily wanting to make sure that we have the right data, it's contracting was going to be potentially an issue. They have their contracts with the providers, and to essentially put additional requirements around the contracting, driving members to those providers, especially in the post-COVID era, was going to be difficult. And so, that might result in some delayed care, especially as these really high quality providers may be having, return services and may have more services than they currently can handle. So that might result in members receiving delayed services. So that was part of the issue, as well as the contracting and just trying to get those providers to accept potentially, some of these requirements that we want to have around the COE in terms of improving the member experience. And also some board members talked about other issues in terms of member dissatisfaction for having to travel or their choice and access of providers, potentially, going to maybe not the provider that they know or a provider that's down the street. And so what we did was to say, hey, taking a look at all this, what we want to do is make sure we have the right data and reinvestigate and make sure that we are headed in the right direction with the COE in terms of understanding the data, understanding which providers are the best, and what we can do to help members understand, to get that information over to the members in terms of what is a quality provider, what are the actions you can take to make sure you're best situated for having these surgeries, as well as working on, as we do that, potential plan designs. What are ways to steer members beyond just discussions, but what are the best ways to get members to the high quality providers? So that's really where we're going. Any questions before we move on? Next slide. So where are we going? So no plan design changes are being contemplated, at least for the next year or so. The year following that, we may start developing some plan design changes, but right now, everything's pretty much going to be status quo. We are working on this. We are getting the data, and we will develop those facility metrics and start working on outreach to providers, to plans, and to the members to kind of to get that informational, educate the members and providers and plans as to what we think is high quality, have those conversations with those three, interested parties, and, more as well. The boards are definitely members, people of interested parties in terms of this project, but, really educate everybody and to get that consensus to help drive this process forward. We are running into a little bit of a glitch with the data. We are kind of behind a little bit now, but we are working as hard as we can to get that information and to really get the COE, at least the data sorting and everything, analysis done in the second half of this year. So that's where we are going over the next year. Next slide. Some considerations where we would want to educate members. As mentioned before, three of the main stakeholders are the carriers. We will work with the plans, and we'll have to work with them to help, drive what we think, is quality. We will work with providers. And we also want to work with OEB and PEBB, the boards, as well as the members. So the actions that we're going to take for these three interested parties include, for the carriers, trying to get them to, I guess, identify those members before they have the surgery, to get them educated, to get those actions, to make sure that the members actually, qualified for the surgery, prior auth, and that they are in the health condition that would help them get through the surgery as best as possible. So what we would want to work with the carriers on is to really get that treatment decision support, to get members early on in the whole healthcare, episode. Do they need the surgery? Are they qualified for the surgery? Get the carriers to help identify whether they do meet those conditions. And to then also manage the case if they do go through on the surgery. For providers, what we want to do is we want to communicate with them about, quality, what you can do to help in, potentially where they might fall a little bit behind or where they are good, to find out what they are doing right, what their facilities are doing right to be that high quality, to prevent those readmissions, to prevent those complications, as well as what can they do to help identify and get those members in the best place. And Cindy's going to talk a little bit more later on about what we have identified along with the plans in terms of what we can, the different metrics on what would essentially qualify a member for having those surgeries. But we want to work with the providers, to achieve those metrics, to make sure that their health conditions are appropriate for the surgeries. And so that's part of the communication that we're going to do in the next year or so. And then there on the right, on OEB and PEBB members, what are we going to do? We're going to try to really communicate with them. Some ways is to provide access to, what we find as high quality providers, get those communications to them. What's the best way of reaching them, and trying to reach them early in the health, in their episode. Maybe when they're doing physical therapy, with the primary care providers, how is the best way of reaching them? Is it going to be through materials? Do we have to go through providers to do that? Media campaigns? We're going to try to work with a communications team and the staff to find out the best ways to educate the members in terms of what would be high quality and to help direct them to those high quality providers. Any questions or comments before we move on? Okay. Next slide. So this next slide shows some values, 13 of them. They're that the IWG has voted on and recommended to be adopted as values in terms of trying to, what is the goal of the COE and how are we going to try to, essentially achieve those goals. So these guiding principles, I think, they are rooted in the AAA, so a lot of them will probably be pretty in line with what the PEB board has adopted. But these are some of those values in terms of, the AAA is the guiding, North Star. You want to get metrics and data and, maintain equity, avoid unnecessary care, ensure that members, are utilizing intensity surgeries potentially, lighter intensity services before getting like the higher intensity services like surgeries, and to help providers and facilities become high quality. So we want to essentially do all of these while allowing the members to make the decision, but make those decisions on an informed basis, to get them the information, to understand what they're getting into, and to make sure that they know that surgery is not a magic. It's not necessarily going to be a cure-all. You have to be right. You have to be right for that surgery. They have to do certain steps in order to make sure that your results after the surgery, you're actually going to be better than where you are. We don't want to have complications. We don't want to have readmissions where they have to have another knee surgery or hip surgery. We want the member to be able to achieve it and not have those unfortunate complications, which do happen a few percent of the time. It's not that many, but when they do, they are very impactful. So these are some of the guiding principles, values that the IWG board has adopted. Next slide. So the project plan, we did talk a little bit about this, but just to reiterate, for the current time period, we are going to look at the APAC data and to communicate and share that information to members, providers, and plans to impact those care decisions, hopefully early on in this case. Phase 2 for the following year, we are going to essentially look at potential plan design, incentives, disincentives, and to talk about different potential contract requirements and warranties, bundled payments potentially, to make sure that a full COE is being implemented, not just education, but the cost impact of that as well as some of the care metrics and outcomes that we want to achieve in this case. So that's going to be phase 2, which is in the next year and a half. Next slide. Just the project plan in a little bit more detail. As I mentioned, we were hoping to review data by now. We are running into a little bit of data issues, so hopefully we will get that resolved and sorted in the next few months, couple months before the end of the year. But these are some of the things that we are going to be looking at least in the short term. And then the next slide. As mentioned, the following phase 2 with the contracting, potentially, the board did adopt travel benefits, but potentially maybe improving those travel benefits for COE in this case. So that's something we're going to be looking at in the year 2. But that's our current project plan. And then next slide, please. So as mentioned earlier, we are trying to talk to the providers, talk to the plans about the best ways to situate, what would qualify a member for surgery for this potentially invasive surgeries. And if they don't qualify, what kind of other conditions or what kind of therapies or actions they can take to achieve that. And so in conjunction with Dr. Tom Siltabo and the plans, we did come up with some steps, some recommendations on what might qualify, as well as some alternative therapy and conservative treatment actions. And I'm actually going to turn this over to Cindy to talk about the next few slides in terms of what we have identified in terms of ways to help members in terms of prior to the surgeries. Cindy.
Thanks, Emery. Yeah, so, basically we're looking at kind of the quality approach of the providers. And so we want to make sure that members who present with joint issues that, they really have tried some of those less invasive procedures, prior to going to surgery. We want to make sure they've tried physical therapy, that, if possible, they've lost weight, used anti-inflammatories, those kinds of things. There are some other things like injections and those type. Some of them are a little bit controversial. So just depends on plan coverage and medical necessity around those. But definitely, as we look at quality, we want to make sure that the providers do have a policy and a process for making sure that members have gone through sort of conservative therapy before they move on to surgery. You can go to the next slide. So we've outlined a few things here that for members who are going to go to surgery, your top quality providers are really going to look at members very holistically to make sure that they are, we call it optimized, but basically that they're in the best condition they can be in to have a good outcome. So there are some things we know that contribute to less than favorable outcomes. Lead to complications, things like that. And folks who have diabetes or other types of chronic conditions are definitely at a higher risk for those things. But we would want the providers to be assessing for all of these. And I can go through these in any amount of detail that you guys would like, but basically they're, at a high level, we want to make sure that they aren't suffering from any anemia. Again, all of these things are associated with complications, strokes, infection, all of those types of complications. And that's why we really would want providers to be focused on these. And then we do have sort of on the right-hand side listed kind of what would the provider do, right? Okay, if the member's anemic, then what's the orthopedic surgeon going to do? And so these are just some of the things, they're going to collaborate with the primary care physician, potentially supplement with oral iron, potentially even IV iron. If needed, they could potentially have a preoperative transfusion, something like that. So for each of these steps, we tried to kind of outline, what the clinical goal would be, why that's important, and then what strategies would be used to sort of get the member in the best shape they could be in for their surgery. And these are all things that are pretty accepted in, the orthopedic community. The American Academy of Orthopedic Surgeons supports all of this. So, these are definitely research-based things that we know can impact outcomes. A1C level, for example, we want to make sure that their A1C level is controlled. We don't want to take an uncontrolled diabetic into surgery and then, potentially have complications related to that. Albumin, so this is really around nutrition. So we want to make sure that members are, in the best nutritional status that they can be as well. So again, thinking very holistically about what are all the things that could impact the member and the outcome of their surgery. You can jump to the next slide. So, BMI, we do know that a higher BMI is associated with an increased risk of complications. So definitely want to work with members to get their BMI down as low as possible before moving on to surgery. Want folks to be tobacco free. We know that smoking is associated with complications. And then the last one there is MRSA colonization, doing nasal swabs to make sure that members don't have sort of a lingering MRSA in their nasal passages that could potentially lead to an MRSA infection of their wound or their after their surgery. So those are sort of the 6 things when we talk about providers making sure that members are optimized or in optimal shape condition to have a really successful outcome. Those are the things that we're focused on. And Emery, I don't think there's another clinical slide, but.
No, I don't think so. But I guess, in terms of the project, we are working on steps. I mean, it is definitely going to be education only, at least over the next few months. But we do want to, keep those conversations going with everybody that's going to be impacted, the providers and plans and members, and, potentially make this a much bigger, more holistic, I guess, COE than just education to help not only improve the care, but the cost. We move on and you improve the experience for the members as well, in terms of maybe having like a concierge type experience if you're going to have those surgeries. to help guide them to, throughout every step, if they're having a caregiver coming with them, if they do have to travel, making sure that they can get the hospital room, they can get the meals, and everything that's there for them. So that's really kind of step 2. But step 1 really is to educate, to get everybody on board and to get that data and to really understand who are the highest quality providers, and to have them start getting them to do those things that Cindy mentioned, to identify those members and to prevent complications and other issues, however we can, at least in this first stage. So with that, I'll turn it back, if there's any questions to you, Coach Vice Chair. If there's any other comments, questions from the board?
No, just thank you. That's very informative.
Thanks for that presentation. I do have one question about how the Centers of Excellence data and metrics evaluation takes into consideration facilities that take a higher proportion of at-risk patients because their outcomes may be worse for reasons more related to structural discrimination, poverty, other kinds of barriers, support at home for post-operative care. Getting diabetes under control is harder for people who are working 2 jobs. These kinds of predictors that set up facilities with higher risk populations to come out more poorly on generalized metrics in terms of how their outcomes look, not because they're not following best practices, which I appreciate. Best practices are an important foundation for this, but to ensure that we're not discriminating against facilities that take a disproportionate number or a higher number of at-risk clients, whether or not those clients are PEBB members or OEB members. How does the analysis take that into consideration? This gets super complicated when we start trying to ground ourselves in equity, and I don't know what that analysis looks like.
Yes, I think the biggest thing with that is making sure we have the right data, and making sure we have the right data in terms of
You're not all German. Wait for them to tell you you're good.
Sorry. Trying to make sure the best data to make sure that we can identify those members who are potentially, and I'm not sure we do have that information, to tell you the truth. I think we're going to try the best we can to get some of it. We have, I don't know if it's we've taken a little bit of a look at OEB information. They do have some race ethnicity data, and we've kind of started taking a little bit of a look at that, but I don't think we necessarily have the income data. We'll have to take a look at that. We can try to meld that with, that's an issue with PEBB, trying to meld that information, get it in. We are going to look at Medicaid separately, so that might get at some of the income issues, but I don't think I have a great answer for you right now. We're going to try to sort it by the data as best as we can and see what data we have available and look at some of that information, because yes, it is an issue. We are going to look at risk adjusting some of those as well. So, maybe not impacting those facilities that do take the higher risk members and have a little bit worse outcomes, just because, in that case, whatever the reasons for those higher risk factors. But we are going to definitely look at it. It's definitely a concern of mine. I think there was a study in Virginia or something like that. It was like with the VA hospitals about congruence of the surgeons, or just like with the members race, and that some members might have been like minorities who ended up getting what I will call the B team of surgeons and having worse outcomes as a result. And that, potentially the white higher income members would get the A team and have the better results. That's, just making sure that not that everybody has the same access to the highest quality providers. And I think that's part of what we're going to try to do with the COE. Whether we can actually get at that information, I'm not sure. We're going to try our best, but we'll see what we can do. Cindy,
All
was there
peers,
anything?
all claims.
Yeah, go ahead.
Sorry. All pairs, all claims is a really interesting data set with some great breadth, but a great deal of I don't know, variability perhaps on some axes. And when we start talking about cultural congruence between providers and patients and the outcomes associated with that, and then trying to put that analysis into a matrix that that has some of the inputs that you just described in terms of like the B team or providers who don't have such good outcomes. It just seems like something that's really important to keep in mind as you go. And I appreciate your intentionality around that as you try to figure out how to do these analyses in a way that gets at the issues that are of most importance to our members. Thank you very much for that. Any other questions or comments about this report? Hearing none, that closes out the update on Centers of Excellence work group. Then I'd like to open it up for public comment. Do we have any public comment or other business to attend to at this time?
There's no public comment, Dawn.
Thanks, Rose. Any other business that we need to attend to? Hearing none. Again, still technical difficulties. Thank you all for your participation in this very productive and efficient meeting. Thank you for the updates and report outs, all the research and support that you are providing, the Mercer team and the staff. And anything else for the good of the order? Hearing none, have a wonderful month. And this meeting is adjourned.
Thank you, Don.
Oh,